Good morning. My name is Jeanne Tshibungu, and I'm going to talk about the preterm birth. First, I will present the presentation plan. I will start with the problem statement, then I will describe the issue. After that, I will propose 3 interventions and the evaluations of these interventions. And then I'll talk about the challenges, solution, and then I will end with the logic model. Preterm birth is when we have a birth before the 37 weeks of gestation. In Louisiana, the incidence of baby born before 37 weeks is 14%. And these babies come with many complications. They have a low survival. They can present cerebral palsy or physical deficiency and or intellectual development delay. The ethnicities that are more presenting this problem are African American. We have 15.6% of African American is preterm birth, followed by the Indian Alaska women for 12.1%. The cause could be multiple pregnancy, infections, diabetes, hypertension, or early labor. The reason of preterm birth are the many obstetrical interventions, or women very young, adolescent and young women have this problem of preterm birth very frequently. Women who have been through fertility treatment, or women who don't have had correct or have access to prenatal care or postnatal care, and women who have been through early labor inductions, like just the induction for pregnancy or cesarean, and also there are no reason known, they are just a preterm birth spontaneous. And regarding the ecological model, I will talk about the factors that promote preterm birth and the factors that hinders health regarding preterm birth. At the individual level, what promoted women going through prenatal care, for example, they are less at risk of having preterm birth. But women who use drugs or tobacco, they have a risk of having preterm birth. Factors which promote at the interpersonal level is the education. Women educated usually they have less this problem, and this can prevent. And women who have a violent relationship with their partners, they can have the problem of preterm birth. At the organization level, you have the NGO who advocate for women and are helping pregnant women. That will be very helpful. But what hinders is the women who have been through assistive reproductive technology. Many times they have twins, multiple fetus, and these babies usually they are premature babies. At the community level, Medicaid is very helpful for women to keep their pregnancy much longer and to avoid all this complication of preterm birth. But poverty is a risk factor. At the policy level, we have seen that women who can have access to leave paid time during their pregnancies usually are having their babies at term, but women who are working night shifts many times can have preterm babies. And the proposed interventions are 3. The administration of magnesium sulfate to pregnant women have been very helpful, and it can protect them for the babies for having the neurological defect, and it can also delay birth. And policies in hospitals, maternities, and in physician office could help reduce the elective delivery before the 39 weeks of gestation, And there's also the intervention of the smoking cessation for pregnant women. This intervention will be first starting with the meetings with all the stakeholders, the physicians, the public health officials, the nurse, midwives, and the NGO who are advocating for pregnancies, with the correct term of pregnancies, and trying to lower the preterm birth. And we will be also in this intervention recruiting pregnant women. We will be training the staff, and we will develop protocols and standards of procedures, and regular supervision will be organized. And the evaluation to see if the work is going well will be to know, for example, the number of healthcare providers who have increased their knowledge of the guideline they have to follow, like, for example, the guideline to quit smoking, which are the 5A, and we will have to know the number of healthcare providers trained and the number of healthcare providers who are applying the new procedures and guidelines. And also, we will have to make a certain number of supervision and then follow that. That's a way to monitor the activities. And how will we measure that the interventions have been successful? We will have to know the number of pregnant women who have been assessed, the pregnant women who have taken magnesium sulfate, and the number of early labor induction, for example, how many babies were born with neural defects, the number of pregnant women who have stopped smoking, and in definitive, we will have to see that there's a reduction of preterm birth. And the challenges are the insufficient information women can have access to. And also the physician and the nurse, that can be a barrier because they can be suggesting to women to have induction or early induction. With the information, this healthcare provider could be very helpful. Another barrier is if there's not a strong collaboration between the stakeholders, or if there's insufficient funds. And the solutions are that we have these campaigns that are going on with the March of Dimes, for example, and the Association of Obstetricians, and the government, who is very involved. Now the logic model. You see in my logic models, they are the input, all these input like the staff, the funds, the training material, the supplies, and the skilled trainers. When all this is in place, then the activities can be realized, like selecting the sites and recruiting the women, the training, and the development of protocols, which in their turn will give us the healthcare provider who will be trained, and then the policies and the standard of procedures that are displayed. And with these outputs, then we have the outcomes at short and intermediate term, and the last impact, which is the long-term outcome, which is the reduction of preterm births. Thank you, and I hope that this intervention could be applied and implemented in the Department of Health of Louisiana. Thank you very much.